So let's start with the part 7 neuroanatomy. So we have just started with the thyroid gland. You can see the important question. Thyroid gland is present within the pretracheal fascia. This is the thing which causes movement of the thyroid gland with degglutination. So which is attached to the thyroid cartilage and hyoid bone. So when hyoid and thyroid cartilage, it moves up and down because of degglutation. Thyroid gland itself moves up and down. So regarding two important nerves around the thyroid gland, most of the questions are coming regarding superior laryngeal and recurrent laryngeal. Superior is above, recurrent is below. So the nerve which is coming from above is superior laryngeal. You can see here, this is the internal carotid artery. This one is internal carotid, this is external carotid artery. And then this branch is the from external carotid artery, superior thyroid is the branch. You can see this is superior laryngeal nerve. It has internal division and external division. So external laryngeal nerve arising from superior laryngeal nerve, it passes close to superior thyroid artery. So to ligate the gland, it has to be close to the gland. Artery has to be ligated close in the superior level as it is. You can see nerve and artery very close. This is external and this is common carotid. This is arch of aorta. There can be possible thyroid artery and this is arch of aorta. On the right side you can see brachiocephalic trunk. This is subclavian. This is common carotid. From this subclavian, this is the first part of subclavian, thyrocervical trunk. You can see from this thyrocervical trunk, inferior thyroid artery. This is thyrocervical trunk. You get the branches, thyrocervical branch, and this is thyroid branch coming, and it's called as inferior thyroid artery. You can see it is a branch of vagus nerve. This recurrent laryngeal nerve is a branch of vagus nerve. Here you can see lights moving like this. So inferior thyroid gland has to be ligated away from the gland. This artery has to be ligated away. As you come close to the gland, these are very much artery and the nerve is close at the inferior level. So it has to be ligated away somewhere here. So this is about recurrent laryngeal nerve. Palsy of the superior laryngeal nerve. Any injury to superior laryngeal nerve will lead to close to the external carotid muscle internal to the mucosa above the vocal cord. Injury to superior laryngeal nerve cause voice fatigue or singer's node, you can see. And recurrent laryngeal nerve is close to the thyroid artery, all muscles except cricothyroid. Cricothyroid is supplied by superior laryngeal nerve. That's why cricothyroid is gone, singer's nodes are gone. Inferior thyroid recurrent laryngeal nerve supplies all the muscles mucosa below the vocal cord. Then complete vocal cord, unilateral causes hoarseness, bilateral causes aphonia. What is the difference in aphonia means respiratory difficulty, unilateral means there is little bit sound is becoming dusky and horsey sound. Unilateral partial causes dyspnea, bilateral causes stridor. So complete voice. Blood supply superior thyroid artery, external branch of external thyroid, first part of subclavian artery. Thyroid artery may arise from the brachiocephalic. All these three are the questions. These three: superior thyroid, inferior thyroid, thyroid edema. So you can see venous drainage. What is the difference? This drains into internal jugular vein. Just go and have a look at the picture. This is upper pole, this is central part, this is inferior pole. This is superior thyroid vein, superior thyroid, middle thyroid, and inferior thyroid. So there are three veins. While in the arteries, there are only superior and inferior thyroid artery. So coming to parathyroid glands, the most commonly asked question is superior parathyroid is from the fourth pharyngeal arch, inferior thyroid from the third. So mainly four glands, mainly a posterior aspect of thyroid gland, inferior thyroid besides common carotid histology. Oxyphilic cells. Again, this parathyroid gland, they have got oxyphilic cells. And most of the questions, follicular malignancy, oxyphilic cells are present. So parathyroids are supplied from inferior thyroid artery. This is important thing, inferior thyroid artery. So while reading this, we have to remember this. Now coming to the larynx, you have got the structures. Now true vocal cord is also called as rima glottis. You can see this is epiglottic cartilage. This is the hyoid bone, lesser cornu, greater cornu of the hyoid bone. This is the thyroid cartilage. Epiglottis, thyroid, lesser. This is thyroid cartilage. This is vocal cords in between the thyroid cartilage. These are called as arytenoid. This is cricket cartilage, epiglottic folds, arytenoid cartilage. These are now you can see this is the arytenoid cartilage. So the central part is called as glottis. Above this is called supraglottis. Below this is subglottis. Now, first is hyoid bone is highermost. It is at the level of C3, thyroid at C4 and C6. This is the question most commonly asked. Cricket cartilage is C6, thyroid cartilage is C4, hyoid at C3, 3, 4, 6, HTC. Now, if you see true vocal cords, rima glottis is the narrowest part of the two vocal cords, falls in between the ventricle. Nerve supply, superior laryngeal nerves, lymphatic drainage, vocal cord has got no lymphatics. This is one of the question. Supraglottic go to upper cervical, infraglottic go to deep cervical. So muscles of the larynx, when you just have to remember this vocal cord, this is open, has got arytenoid cartilage. So opening of the vocal cords by posterior, you go from the posterior cricoarytenoid muscle that opens, and closing is from the side, lateral cricoarytenoid. From the lateral side, closing, opening has to be from the posterior. Tense cricothyroid muscles causes tensing. Cricoid 6 levels, it is complete ring, so cannot be compressed. This is one of the question. Cricoid cartilage is complete ring. So this structure at the level of cricoid cartilage. Cricoid cartilage is at C6. What are the important things? There are two changes, 1N, 1M, 3A, 1V. Two changes, trachea converts into, larynx converts into trachea, pharynx converts into esophagus. Two tubes which are changing. One is larynx into trachea, pharynx into esophagus. Then a nerve is sympathetic cervical, middle say the cervical sympathetic ganglion, central ganglion of the sympathetic chain is there. Muscles, superior biliofomoid crosses the corslet. Then one muscle is there. 3 arteries and 1 vein. Which is the carotid artery can be compressed again. This is the C6 vertebra. The important part, carotid artery is compressed at C6 vertebra. Vertebral artery entered the C6 level, not in the C7 level. Inferior thyroid artery is going to the gland. Middle thyroid vein is near this. Cricothyroidectomy. This most common question which is asked. It is in the cricothyroid membrane between thyroid cartilage. In emergency, you have to just, this is thyroid cartilage, this is cricoid cartilage. In between the two, there is thyroid cricoid membrane. So definitive tracheostomy is done midway between suprasternal notch and the cricoid cartilage. This is cricoid cartilage lowermost. In between center of this, definitive thyroidectomy is to be done. And this is just emergency. Staph muscle retracted thyroid stomach may be cut. Stomach may be cut here or retracted. Open the tracheal rings 2, 3, 4. 2, 3, 4. So just remember 2, 3, 4. Leave the 1 and 2, 3, 4. During tracheostomy, least affected branch is ascending pharyngeal branch of the artery. Even thyroid surgery ascending pharyngeal, and the most commonly affected is isthmus. So these are the branches of ascending pharyngeal artery. You can see it's behind. That's why it is not involved. Now coming to larynx, the question which is commonly asked is, it has got actually 3 constrictors, superior, middle, and inferior constrictor muscle. Below that inferior constrictor muscle, you get a cricothyroid. This is the inferior constrictor, and this is the thyroid, and you can get cricopharyngeus muscle. From this, whenever the diverticulum is coming to the Sencke's diverticulum. Again, you can see here is the inferior constrictor muscle. There is a thyroid cartilage. There is a cricopharyngeus muscle. In between the two, there is Sencke's diverticulum, false diverticulum. It can be through inferior muscle, between the inferior constrictor muscle and cricopharynx, between cricopharynges and thyropharynges. So coming to tonsil, it is supplied from tonsillar artery, which is a branch from the facial artery, external parietal vein to facial vein. So the hemorrhage after tonsillectomy is basically from the external parietal branch of facial vein. Venous bleeding is there. Jugulodiastolic is the. So tongue has got a very typical nerve supply. Anterior to third tongue. General sensation is supplied by the lingual nerve and taste sensation by the chordating pinea. You can see sensory lingual nerve is a branch of V3, and that is branch of trigeminal. It supplies the general sensations, and taste is by chordating pinea, branch of facial nerve, which is carried by the lingual nerve. So anterior to third, posterior to third, general taste sensation by the glossopharyngeal nerve. And posterior most part, motor is by hypoglossal seventh nerve, except palatoglossus, which is supplied by the 10th nerve. So tongue epithelium is basically stratified squamous epithelium. Squamous cell carcinoma of the tongue is the risk factor is against smoking, alcohol, old age. Muscles, internal muscles and external muscle, extrinsic muscles, styloglossus, hydroglossus, genoglossus, palatoglossus, internal transverse oblique muscles, superior. So all the basic muscles of styloglossus, hyoglossus, genoglossus are from the hypoglossal nerve, except palatoglossus, which is applied by the near the palate means vagus nerve. So what does styloglossus? It is from the styloid process of the tongue, elevation of the tongue. Hyoglossus, retraction, depression of the tongue. Genoglossus is the protrusion of the tongue. Genoglossus is from anterior part of the mandibular supply, so it helps it protrude the tongue outside. So genoglossus is protrusion of the tongue. Rest of the things, elevation, posture, and everything. The interesting, the important part is lymphatic drainage. You just go to this figure. Tongue has divided into 4 parts. Anterior is the submental. The T is submental. Interiormost tip is the submental going. Then middle, anterior, middle, and posterior 3 parts. Anterior, if you divide 2 halves, right will go to right submandibular, left to go to left submandibular. In the middle part, it will be crisscross. Both the posterior part, deep cervical. All these lymphatic drains will do deep cervical lymph node. Coming to the palate, palate has got a hard palate and a soft palate. Hard palate is from the premaxilla palatine processes containing 3 foramina: nasopalatine, greater palatine, and lesser palatine, containing blood supply and sensory supply to the palate. Greater palatine, nasopalatine, and lesser palatine nerves from the maxillary to the soft palate. You can see here these are the nerves: nasopalatine from anteriormost, greater palatine in the between, and lesser palatine posteriorly. And you can see the arteries, greater palatine artery. If this is the palate, you can get pillars centrally use. This one is center is uvula. This is palatopharyngeus, this is palatoglossus. 2 pillars, in between 2 there is tonsil here. This is the posterior surface of tongue, this is the anterior 2/3 of tongue, and you see this is pterygoid humulus. Soft palate is formed by 5 muscles: tensor palati, levator palati. So here is the levator palati, tensor palati muscles, which are supplied by vagus nerve, except tensor palati by the trigeminal nerve. We are seeing trigeminal just coming out of this maxillary mandibular. So mandibular nerve is the motor nerve. It's supplying to tensor palati and levator palati. Then the other 4 muscles, levator palati, palatoglossus, palatomula, all these are supplied by the vagus nerve. Now coming to the next important topic about nose, anterior modal nerve is supplying. You see the nasal, these are the branches. Infraorbital branch, this is infratrochlear, supratrochlear. So if you see the origin of these nerves, these are from the ophthalmic division, maxillary nerve and ophthalmic division of trigeminal nerve. Supratrochlear and infratrochlear, if you go and check again, this maxillary nerve, trigeminal nerve has got sensory. So nerves, these are sensory nerves, external branch of ethmoidal, infraorbital. Coming to blood supply of this, most of the questions which is asked, these are the anterior model, posterior model, branches of ophthalmic artery. Which is a branch of internal carotid artery? Is first branch, and you see posteriorly there is external carotid artery. From this you get a branch. The one branch is facial. The first branch is mm, superior thyroid. Second branch is lingual. Third branch is facial. Fourth branch is maxillary. From this facial, you get a superior labial, septal branch, and little branch. Then from maxillary artery, you get a greater palatine artery. From this greater palatine, you get blood supply to the little area. So this question is asked: greater palatine, or which is the branch of maxillary artery? Branches phenopalatine artery is coming from posterior side. Is again forming this contribution to little area. Septal branch, now blood supply, septal branch is superior labial artery of the facial artery. This is septal branch in the center. And nasopalatine artery of the maxillary. This is a branch of maxillary. From sphenopalatine branch, maxillary artery, branch of sphenopalatine artery, then greater palatine artery of maxillary artery. Greater palatine, sphenopalatine. So these are these. Anterior model from the ophthalmic artery, posterior model from the ophthalmic artery. Anterior Kesselbach triangle or little triangle is anterior most common from sphenopalatine. Sphenopalatine, we have just seen this branches sphenopalatine. This question: posterior Woodruff plexus less common, often seen in the older patients. Hypertension, sphenopalatine again is the common branch. Superior epitaxis, anterior posterior middle branches of epitaxis. By coming to the lateral wall of the nose, it has got the nasal openings, the various openings in this lateral wall. Inferior meatus, most inferior, you can see this red color is the nasolacrimal duct is opening. This the middle meatus has got so many openings. The green color frontal sinus you can see here. Then blue color ethmoidal, anterior, post, middle ethmoidal, and posterior ethmoidal is opening into superior meatus. You can see superior meatus, here is posterior ethmoidal, anterior middle into middle meatus. Then ethmoidal, anterior middle. Then maxillary meatus is also opening into the middle meatus. Then superior sphenoid recess into the sphenoid recess. Upper is the superior sinus. So this is about frontal sinus, anterior and posterior ethmoidal sinus. There is an interesting lymphatic drainage. Lateral canthus, pretracheal, medial canthus goes to submandibular. If you see the ear, the supply of the ear auricle is from greater auricular, lower part of the ear to the anterior posterior gives also branch to the angle of mandible. So this is the question. Greater auricular supplies to the angle of mandible, lesser occipital upper part of posterior part, skin behind the ear, auriculotemporal to the upper part of anterior gives temporomandibular joint. All these three are the questions. Temporomandibular joint, one question. Lesser occipital to occipital part, and nerve to greater auricular is supplying to lower part of the uvula as well as angle of the mandible. Angle of the mandible, temporomandibular joint. Two different things. Temporomandibular by auriculotemporal. Angle of the mandible, greater auricular. Greater auricular is commonly injured in parotid artery, parotid gland surgery. It is more superficial. So nerve supply, artery branch of vagus. There are 4 to 5 nerves are involved here. 10th nerve, auricular branch, facial nerve, sensory nerve, auriculotemporal nerve of the trigeminal. 5th nerve. Cancer causing to refer to the auricle. Then you see eardrum. This is like this. It's called as drum is this. This one is the handle of the malleus, and this is the flaccid part. This is tense part. Cone of the light, 1 centimeter in diameter. From inner surface, you see there is lining by the mucous membrane. For outer surface is stratified squamous epithelium. Chorda tympani pass like this from the. There is the chorda tympani. You can see the course is passing near the fascia. There the handle of. There is the handle of malleus, incus, malleus, and stipes. So handle of malleus. The supply of the middle ear in eustachian tube. So you can see the nerve supply of middle ear eustachian tube. Again, it is 975. Glossopharyngeal middle, superior middle, and tonsil. Why? That's why the tonsillectomy patient felt pain refer to the ear. Facial nerve to stapedius, and so whenever there is hyperacusis lost to this facial nerve hyperacusis, the chorda tympani passes medial to pars flaccida. Trigeminal nerves to tensor tympani. Tympanic membrane roof of the middle ear cavity. Anywhere if there is injury into the middle ear cavity, then blood or the CSF is coming out of this, affecting tympanic CSF like CSF arteria. So middle ear infections or otitis media eustachian who connects middle ear to the eye. So sometimes mastocytis infection going to the jugular. You can see the mastoid and jugular vein. The upper one third goes to superior parietal lymph node, lower third goes to the. Now coming to venous drainage of the neck, we have seen these superior sinus. This is coming to the interjugular vein. Sigmoid sinus opening into jugular, interjugular with the larger vein which comes down to superior vena cava, joins with subclavian vein to form in the superior vena cava. Then these are the small vertebral veins. They come join to the superior surface anatomy of external vein is a posterior triangle. If you see, these are the surface anatomy of internal and external jugular vein. Anterior carotid triangle is like this crossing in this manner, while the interjugular vein going straight above the triangles. From lobule of the ear to the middle end of clavicle is internal. From the angle of mandible to the middle of the clavicle is external. Artery supply of the head and neck, arch of aorta, you can see on the right side is brachiocephalic, left side directly the internal carotid artery and subclavian artery is arising. So whenever there is any embolus into the left subclavian artery, so the blood is flowing like this and circle of Willis is coming back. So that is subclavian syndrome. Then brachiocephalic artery that divides the right common thyroid artery may be present. Common carotid can be compressed on the cervical vertebra at T6 vertebra. Cervical separation passes behind common carotid, divide at C3 level, upper part of the thyroid carotid, internal and external carotid. Again, these are the external carotid artery neck branches. We have seen four in the anterior side: superior thyroid, lingual, facial, maxillary, superficial temporal continuation, then posterior, occipital, and ascending pharyngeal artery. So internal carotid has no branch. The first branch is ophthalmic artery, surface anatomy. Branches of ophthalmic artery, first branch, anterior cerebral artery. This is the important brain nerve supply to the brain. We'll just stop this part here and get freshly done from the important brain supply, nervous supply, blood supply to the brain.